Hello everyone and welcome to one of the very important lectures in our ECG course today, as we are going today to discuss one of the very common and a clinically significant arrhythmia in our clinical practice, which is atrial fibrillation. Today we are going to learn how to diagnose atrial fibrillation in ECG, and we are going to learn the types and various patterns of atrial fibrillation. Because of course it is an ECG course, we are not dealing with the management of atrial fibrillation according to the guidelines. We are just focusing on the ECG diagnosis and the ECG patterns of atrial fibrillation. Of course, we know the scheme, and today we are focusing on two of these arrhythmias in the scheme, which is AF with rapid ventricular rate, and we are going to give a hint regarding pre-excited AF or AF with apparency, although it will be discussed in a separate lecture, which is the wide complex tachycardia. Let's at first discuss the mechanism of atrial fibrillation. We are not going to go in depth for the mechanism of atrial fibrillation because of course there is a lot of discussion and a lot of theories explaining atrial fibrillation, but we are going to explain the most common theory that is very famous for explaining the mechanism of atrial fibrillation. We have something called the myocardial sleeves, which are extension from the left atrial myocardium surrounding the proximal part of the pulmonary vein near their insertion into the left atrium. These myocardial sleeves may contain like an abnormal electrical activity that may act as triggers for atrial fibrillation. So these sleeves are called the pulmonary vein triggers. These triggers can irritate production of a re-entrant circuit, for example in the left atrium. This circuit can trigger another re-entrant circuit, another circuit, another circuit, another circuit, leading to formation of multiple wavelet re-entries. Each one of them can collide with the other one adjacent to it, leading to its fragmentation, and then each circuit can collide with the other one adjacent to it, leading to formation of a completely chaotic electrical activity in the left atrium. So here we don't have an organized atrial activity. We don't have an organized atrial depolarization like in sinus rhythm. So of course we are not going to have P wave on the ECG because of the complete chaos in the atrium. And also we don't have, for example, irregular electrical activity but in organized form like in multifocal atrial tachycardia, in which there are multiple foci but each one of them fire at a specific time in the cardiac cycle. No, we have completely fibrillating and chaotic atrial activity. So this theory is called the multiple wavelet re-entries series, which is very famous, and depending on it, the basis of the AF ablation procedure is depending on isolating the pulmonary veins electrically from the left atrium. What can predispose this theory or predispose this mechanism, which are the pulmonary veins triggering atrial fibrillation? Because of course if we have myocardial sleeves anatomically, why don't we all have atrial fibrillation? Of course it can be predisposed by many factors, and here I'm selecting the most famous one. It can be predisposed by atrial dilatation, which may occur, for example, in patient with mitral valve disease or patient with LV systolic or diastolic dysfunction. Of course, occurrence of fibrosis may lead to formation of a substrate inside the atrium, which favors the formation of multiple re-entries. As we discussed before in the classification of tachyarrhythmia, we know that re-entry needs presence of an obstacle around which there are two pathways with difference in the conduction velocity and the refractoriness, and of course fibrosis is a very good medium for this. Increased catecholamines, like occurs in sympathetic overactivities, like occur in cytotoxicosis, like occur in stressful situation, all of this can predispose atrial fibrillation. Electrolyte disorders, of course, can be a factor, electrical remodeling, old age, and sometimes it may be idiopathic. So we have this theory, multiple wavelet re-entries, and this theory depend on presence of two factors in order to trigger atrial fibrillation. We need a trigger which induce atrial fibrillation. Usually it is inside the pulmonary veins in most of the cases. Sometimes there are different triggers in other sites, like sometimes in the coronary sinus ostium or in the crista terminalis, but most common trigger is the pulmonary vein due to the myocardial sleeves. And we need a substrate to maintain atrial fibrillation, because I may have a trigger for atrial fibrillation in the pulmonary vein, but because my atrium is structurally normal, this leads to formation of one circuit which doesn't maintain atrial fibrillation and it resolves spontaneously. But the presence of a substrate which perpetuates this atrial fibrillation leads to its persistence, and it may persist, for example, for a few hours and resolve, may persist for a few days, may persist for years, and may be permanent. So for atrial fibrillation we need a trigger and a substrate. Of course, the trigger, as we mentioned, it will be an ectopic focused discharge impulse at high rate, and this is the atrial myocardium with varying conduction velocity and refractoriness, and that explains why the atrial fibrillation is more common in patients with structural heart disease and less common, or not impossible of course, but less common in patients with structurally normal heart. So we need to mention now what are the ECG features of atrial fibrillation. Absence of persistent P wave, because they are replaced by the fibrillatory waves in most of the case, which are called F wave, or sometimes just very fine oscillations in the isoelectric line, but there is no persistent P wave. And here I mean the word of persistent, because sometimes you may see like something seeming like a P wave, but it is not persistent before each complex. In order to measure it is sinus rhythm, I need to have a persistent P wave before each complex. If there is just one P wave, you can see in one of the cycles, but in the other beats there are no P waves, so it is atrial fibrillation. Irregularity is very important features, because here the completely chaotic electrical activity in the atrium would be reflected on the ventricle as an irregular ventricular rate. Atrial rate is nearly 400 to 600 beats per minute. It is very high atrial rate due to this chaos. So this is the most irregular atrial tachyarrhythmia to see is atrial fibrillation. So for example, here we can see in these ECGs that we have these features. We can consider here that we have irregularity and we have absence of persistent P wave. Of course, we are not able to calculate the atrial rate, but just I want to mention to you to put in your mind that the atrial rate in atrial fibrillation is extremely high. For example, someone may say, I see P wave here. It can appear in lead V1. And also it can appear in the strip in lead 2 as arrows determines, but this is not a persistent P wave because it doesn't precede each complex. It is just called summated atrial activity. Here this irregular atrial activity was summated to form a positive deflection before the complex, but it is not persistent. So please don't just look to this wave and exclude the diagnosis of atrial fibrillation because of this. No, it is just summated atrial activity rather than P wave. Here, for example, we can see here that also we may see that this is a P wave, but it is just summated atrial activity. So now we know this idea in order not to put ourselves in misdiagnosis or excluding a patient with atrial fibrillation and omitting giving him anticoagulation just because of one wave that seemed like a P wave before the complex. We can see in this example this very famous pattern of atrial fibrillation. Sometimes we may see these waves. These waves may seem like Soto's appears that we can see in atrial flutter. So may someone mention that this is atrial flutter with variable rate of conduction, which we learned in the lecture before, but these are not flutter wave, they are coarse fibrillatory waves. What's meant by coarse fibrillatory waves? In coarse AF, the fibrillatory waves are large and coarse with amplitude is nearly more than or equal 0.5 millimeter, and this is more common to see in younger age with structurally normal heart, which we usually call lone AF. Although we mentioned that atrial fibrillation is more common in patients with structural heart disease like mitral valve disease or LV dysfunction, but of course it may occur in patients with structurally normal heart like in young patient, and in this case we call this lone AF. In case of fine AF or fine fibrillatory waves, here the waves are just fine oscillation with an amplitude less than 0.5 millimeter, and this of course is more common in older age with severe left atrial dilatation and atrial fibrosis, especially with long-standing persistent AF. So when we see these waves, we can call this coarse atrial fibrillation. And so when the waves are just fine, we call it fine AF, and this is coarse AF. So it depends just on the morphology and amplitude of the fibrillatory waves. We may ask ourselves, if the atrial rate is 400 to 600 beats per minute, why doesn't the ventricle have the same rate following the atrium? Of course, it depends on the AV nodes. The AV node here is characterized by two physiological criteria. It has something called the AV nodal delay, and it has a criterion which is called decremental conduction. Because here this AV node has these two criteria, it doesn't transmit this whole rapid atrial rate. It may just transmit a certain limit of atrial depolarization to the ventricle, leading that, for example, this AV node may show a ventricular rate of about 140 to 150 beats per minute because it doesn't transmit these whole or heroic number of atrial action potentials. So the AV node controls the transmission of electrical activity from the atrium to the ventricle. So we can have another classification for atrial fibrillation after we classified it according to the morphology or the amplitude of the fibrillatory waves according to the ventricular rate. It may be AF with rapid ventricular rate in which the heart rate is usually more than 110 beats per minute. It may be AF with controlled ventricular rate with a heart rate between 60 to 110 beats per minute, and it may be AF with a slow ventricular rate with a heart rate is less than 60 beats per minute. Of course, there are other terminologies which are commonly used in practice like rapid AF, controlled AF, or slow AF, but these are considered misnomers because, of course, AF is always rapid and it is never slow because, of course, the atrial rate is extremely high. So when you mention rapid AF or slow AF, it is like misleading terminology. So better when you comment on an ECG, for example, in your practice or in a report or in an exam, better to use the word AF with rapid, with slow, with controlled ventricular rate rather than these terms. So the AV nodal response determines the ventricular rate. But what determines the AV nodal response to classify the AF into rapid, slow, or controlled ventricular rate? It can be determined by autonomic nervous system activity. Some patients may have sympathetic overactivity, and so when they develop atrial fibrillation, they have very high heart rate and he comes to the ER, not just in the clinic, because he has sudden onset of palpitation and dyspnea. And some patients may have vagal predominance, like for example in athletes, and so when they develop atrial fibrillation, the heart rate is not very rapid and it may be controlled, and so he may present to the OPC, or maybe even in old age he doesn't recognize that he has an irregularity in his heart rate. Medications like negative chronotropic medication, if a patient is taking beta blocker or non-DHP calcium channel blocker or digoxin, he may have a slowing down of the AV nodal conduction, and so the ventricular rate may be controlled or even slow if he is taking an overdose. And if the patient has an AV nodal disease, of course, this with much more limitation to the conduction, to the ventricles. So this is another classification for atrial fibrillation. Let's ask ourselves another question which we asked before in the lecture of AV blocks. Can third degree AV block occur with atrial fibrillation? Of course, yes. Third degree of a block can occur on top of atrial fibrillation, and we discussed this before. Here we can see in this ECG that we don't have persistent P wave, and we have instead fibrillator wave, as we don't have a complete isoelectric line like in junction rhythm. But we can notice that the fibrillator waves are present, but the heart rate is regular and slightly slow. So this is AF with third degree AV block because of the regularity, because AF should be irregularly irregular. So once AF develop irregularity, we should consider development of third degree AV block. And we discuss why, because of course the ventricular rate gets regularized by the escape junction rhythm or idioventricular rhythm rather than being irregular due to the chaotic atrial activity. So when the AV nodal conduction is blocked, at the time the ventricular rate is paced by an escape rhythm rather than the chaotic atrial rhythm. Here, for example, the atrial fibrillation rhythm is bradycardic and there is absence of persistent P wave, but we can't call this AF as complete heart block because it is still irregular despite it is slow or it is bradycardic. So why is the AF with slow ventricular rate irregular? Here AV node is slowed down but it is not blocked. So here this chaotic atrial fibrillatory rhythm is still conducted to the ventricle but at a slower rate, and so the ventricular rate is still irregular despite being bradycardic. So if the heart rate is still irregular, it is called AF with slow ventricular rate. If it is regular at that time, we can call it AF with third degree AV block. So remember this quote that once AF rhythm becomes regular, you should suspect third degree AV block, and AF should always be irregular, even if it is slowly conducted. Let's ask another question. Can AF with rapid ventricular rate be irregular? The patient has a heart rate more than 110 beats per minute, and it seems regular despite being an AF. It may seem regular, but in extremely high rate, but is not actually regular. So let's see this example here. This patient has AF with rapid ventricular rate with a heart rate about 170 to 180 beats per minute. as RR interval in most of the cycles is less than 2 large square. It seems irregular, but it is actually atrial fibrillation. If you try to concentrate in the ECG and use a paper, at the time you will notice slight irregularity that confirms this diagnosis of atrial fibrillation. But if there is a dilemma in the diagnosis between you and your colleague, how could you know? If, for example, you mention that this is atrial fibrillation and your colleague rejects this diagnosis. At that time, we have two techniques. We can produce carotid sinus massage, or we can have an ECG at a speed of 50 mm per second. This carotid sinus massage would slow down the AV node, and so the heart rate gets slowed down, and so it reveals the fibrillator wave and reveals the irregularity. And the ECG at this speed, of course, it would show much more clearly the fibrillator waves, and also it would show you that it is irregular. So when there is a dilemma in the diagnosis, in this case, that someone of you says that it is AF with rapid ventricular rate, and another one say no, it is just SVT, at the time you can use one of these two techniques to confirm or reject the diagnosis. So AF with rapid ventricular rate is never regular, but it may seem regular as a first instance, but when you concentrate, you would notice irregularity. I think these questions and answers may be much more interesting, and that's why I selected this way to explain this lecture. So let's ask another question. Can AF show wide complexes in the ECG? It's a matter of ventricular conduction and depolarization rather than the AF itself. So it's not a big deal. And that's why we have a third classification for atrial fibrillation in the ECG to narrow complex or wide complex. Of course, narrow complex is much more common to see in our practice, that the patient has atrial fibrillation and the complex duration is still less than 120 milliseconds. And it may be, and not uncommon, to see a patient with atrial fibrillation and has a complex of more than 120 milliseconds. It can occur in pre-excited AF, which is a very dangerous and life-threatening situation, and when you diagnose it in ECG, it needs immediate management. The atrial fibrillation, the same as in SVT, may show bundle branch block apparency. Pre-existing or rate dependent, it may occur with atrial fibrillation. It may be left bundle or right bundle. And there is another thing that may cause wide complex, but it is intermittently wide, which is called Ashman phenomenon, which would be explained in a separate spin-off lecture. So atrial fibrillation may show narrow complex in most of the cases. It can show wide complex, which could happen in pre-excited AF or in case of AF with bundle branch block apparency, as in this example, the patient has AF and he also has left bundle branch block. So presence of a wide complex should not omit the diagnosis of atrial fibrillation. Let's come to an important point in our lecture, and I know that many of you, when I explain the issue of the coarse fibrillator waves, that they are not flutter wave, he maybe have asked himself why it is not flutter waves. Atrial fibrillation is characterized by irregularity and absence of persistent P wave because of the chaotic atrial activity, which would have been explained by the multiple wavelet re-entries theory. And the atrial flutter in most of the cases it is regular, like in most of the case heart rate is 150 beats per minute due to 2-to-1 conduction, but it may be irregular due to variable AV conduction, and so it shows the flutter waves which show a sawtooth appearance with regular atrial rhythm. So when you detect the intervals between the flutter wave, you would find that it is completely irregular because it is a macro re-entrant circuit, one circuit inside the atrium. But an atrial fibrillation completely irregular. Even in coarse fibrillator waves, it would be irregular as well. So there is nothing called, please, atrial fibrilloflutter, because it is a malpractice to diagnose some patient as fibrilloflutter just because he has this ECG pattern, which we have seen at the start of our lecture. These waves, as we mentioned, are not flutter waves. They are coarse fibrillator wave, and that's why they just appear in V1. Usually the flutter waves are much more clear in inferior leads, but here they are clear in V1. If you have a little concentration, you would notice that these flutter waves don't have the same morphology, and they are also showing irregular intervals. So flutter waves should not be varying in morphology. They should have the same morphology, and they should not have irregularities, should be regular. So this is not atrial flutter, and this is atrial fibrillation. So presence of this wave should not give you the diagnosis of fibrilloflutter, because there is nothing called fibrilloflutter. Atrial fibrillation has a completely separate mechanism from atrial flutter. In this ECG, we see these are flutter waves. They have fixed morphology and they have regular intervals inside the atrium. Here, when I'm saying regular interval, I am not speaking about the RR interval. I'm speaking about the PP interval, which is meant here the regularity of the flutter rhythm itself inside the atrium, regardless the ventricular rate. So these are flutter waves, not coarse fibrillatory wave, and this ECG shows atrial flutter. And we can see here that the flutter wave are much more clear in inferior leads than in V1. So remember, nothing is called fibrillar flutter in one ECG, but a patient may develop intermittent episodes of AF and at other times episodes of flutter, especially in patients with structural heart disease causing atrial dilatation. So patient may have AF at one point and he have flutter at another point, but in the same ECG, no, it is not one arrhythmia called fibrillar flutter. Let's ask ourselves the last question in our lecture today. What is the common feature between AF and atrial flutter despite different mechanism and different ECG features? As we learned here, AF, multiple wavelet re-entries, atrial flutter is one macro re-entrant circuit. In atrial fibrillation, let's ask ourselves the last question in our lecture today. What is the common feature between AF and atrial flutter despite the different mechanism and ECG features? In atrial fibrillation, it is multiple wavelet re-entries leading to completely chaotic atrial activity. Atrial flutter, it is just one macro re-entrant circuit leading to regular atrial activity. Atrial fibrillation shows absence of persistent P wave. In atrial flutter, we can see clear triphasic flutter waves with regular interval. So what is the common feature despite the difference in the mechanism and ECG features? Both types of arrhythmia, the atrial fibrillation and the flutter, increase the risk of left atrial thrombosis because, of course, the loss of the left atrial kick leads to stagnation of blood flow, especially in the left atrial appendage. And so this increases the risk of systemic thromboembolism. And so patients with atrial fibrillation and also patients with atrial flutter should be put on the CHAS-VASc score in order to decide whether these patients may need oral anticoagulation or not. So this is the common feature that leads that sometimes atrial fibrillation, atrial flutter are discussed in one lecture, and sometimes in literature they may be discussed in the same chapter following each other, because in clinical practice you should detect this atrial flutter because it has the same management regarding anticoagulation as atrial fibrillation. So at the end of our interesting lecture today, we learned today how to diagnose atrial fibrillation ECG, and we learned clearly what are the diagnostic features in ECG for the atrial fibrillation and what are the pitfalls for diagnosis or misdiagnosis. And we learned today the various patterns of atrial fibrillation. We learned 3 ways to classify the atrial fibrillation according to the heart ventricular rate, according to the morphology of the fibrillatory waves, and according to the complex duration. Of course, we didn't deal here with the classification regarding the timing or the duration of atrial fibrillation into paroxysmal, persistent, long-standing, persistent, or permanent, because this is a clinical classification rather than an ECG classification. We cannot classify atrial fibrillation into paroxysmal or persistent depending on the ECG. It depends on the history. And so we learned today the various patterns of atrial fibrillation. Our take-home message today: the key features of AF are irregular irregularity and absence of persistent P wave. And once AF rhythm becomes regular, you should suspect superadded complete AV block, and nothing is called fibrillar flutter, please, in one ECG. Thank you very much for listening.